Perfect. So, good morning, everyone. We are going to talk about new onset left ventricular systolic dysfunction from chemotherapy, and specifically, this is dealing with patients who have sinus rhythm. It's a whole other set of problems clinically and from an oncology side. When someone has atrial fibrillation with heart failure, because then we have to talk about the issue of anticoagulation, which I believe is a whole other topic that has to be included. So what we're going to do is go through a differential of diagnosis of acute left ventricular systolic dysfunction during or after cancer treatment. There is an acronym that I like to use for our fellows, and the idea is it's acute. It's cardiomyopathy of unknown etiology. So every time we go in and we start an evaluation on a patient, we always start with the premise that we do not know what the etiology is. And as we get through this next 30 slides, you'll see why. But it's better to start off with the uncertainty rather than certainties. The role of diagnostic testing and the role of standard heart failure therapy. And part of the thing that I will go over that's a little bit different is I'm really going to focus about how cardiology and oncology have to work together in the decision-making process, because I still think that we don't have a full understanding of what happens to oncology patients when we're cardiologists, and we have to take that in consideration every step of the way as we're evaluating patients and as we make decisions for their management. So what I'd like to do is start off with a case. This only happened within the last several months. So this is a 58-year-old gentleman who has a history of mediastinal B-cell lymphoma. He was treated with a standard R-CHOP regimen for 6 cycles that he completed in August of 2013. Pre-treatment, he did have an echocardiogram, standard of care at our institution. His ejection fraction was 59%. His left atrial volume index was 27 mLs per meter square. We like to look at left atrial volumes in our patients, and you'll see why as we go on, why we think that's important. So he presents in April of this year, April 30th, with a left ventricular ejection fraction of 45%. Normal in our lab is anything above 50%, as it is in most labs around the world, and the strain was also very abnormal at minus 15. He had symptoms of fatigue and shortness of breath. He never had chest pain.
Dr.
When he
Duran?
presented his, yes.
Oh, do you have a baseline strain on this patient so we can see if there's a change?
There was, actually. I'm sorry I didn't include that. His baseline strain was minus 20. Yes. So completely normal. He had symptoms of fatigue and shortness of breath. He never had chest pain. His blood pressure was 156/92, and his heart rate was 92. His EKG showed sinus rhythm with right bundle branch block. That's old. His previous pre-R-CHOP regimen, his EKG showed right bundle branch block. On his physical exam, his lungs were clear. There were no signs of volume overload. His jugular venous pressure was normal. He had a prominent S4 on exam, and he had no lower extremity swelling. And he is, interestingly, free of disease. So he's only a year out from completing treatment, free of disease, no signs of volume overload, some hypertension, and then a small a change in ejection fraction, but just 5 points below the normal range. So the question becomes, what is the etiology of his decline in LVEF, and what evaluations should be considered? Now, one thing I want to make sure that you see is that the total dose of adriamycin was over 400 milligrams per meter square, and he received mediastinal radiation as well. So what evaluations should be considered in part of his initial evaluation? So one of the important concepts to walk away from in the oncology space is that we diagnose and we treat common presentations of unlikely causes of systolic dysfunction in the oncology community. The common causes of LV systolic function in the cardio-oncology community are quite different than what you see in the general population. These disorders have significant role in the morbidity and mortality and future treatment, as well as re-challenge of anti-cancer therapy, and it's important that all of these are considered when you're doing your routine evaluation. So a differential diagnosis in acute cardiomyopathy of unknown etiology in cancer patients is we always consider a stress cardiomyopathy. We also consider sepsis. We especially consider acute myocarditis, especially in patients who are status post bone marrow transplant or stem cell transplant. Transfusion-related cardiomyopathy, anthracycline, tyrosine kinase inhibitors or multikinase, thyroid disease, as well as cardiac amyloid. And if you go back to this particular case, the patient was not septic. Certainly acute myocarditis would be something you consider. He did not have stress cardiomyopathy because on the echocardiogram there was not the characteristic basal contraction with apical ballooning. Transfusion-related would certainly be something to consider, more likely in patients who have myelodysplastic syndrome. Anthracycline would be high on the list. You never receive a tyrosine kinase. Routinely, we check TSH on all patients who present with new onset cardiomyopathy. Cardiac amyloid we would consider, especially in patients who have myeloma, not particularly in somebody who has R-CHOP, but certainly would be something we would consider. So there's variable causes of chemotherapy-related systolic heart failure. The recent data suggests that the pathology of the disease can be quite different if you're looking at anthracyclines versus tyrosine kinase inhibitors. The approach, it is highly, very, very important that you consider underlying drug-drug interaction. And I'll give you an example. If someone has a history of dyslipidemia, and they are, for example, on Lipitor, there is a lot of potential for drug-drug interaction, especially if those patients have had a bone marrow transplant or stem cell transplant. So we typically will use drugs such as Crestor, mainly because Crestor is metabolized in the gut, not in the liver. So we don't tend to see as much with myositis and as much with drug-drug interaction. The volume status of the patient is highly important in cancer patients. A lot of them are still experiencing anorexia. They may not have much of an appetite, and it can be difficult to get them on an ACE inhibitor. And then their blood pressure and heart rate can be very challenging as well. A lot of them don't typically present with high blood pressure. They may present with low blood pressure and a fast heart rate. So our approach is always to consider in the U.S. the most common cause of systolic dysfunction is always ischemic heart disease, even if they've received anthracyclines or TKIs. So we always consider a CT of the coronaries or a coronary angiogram, whichever one can be done, and that's also heavily weighed on what their platelet count may be. We aggressively look for reversible causes of cardiomyopathy, and we do a very quick dose escalation of ACE inhibitors and beta blockers. That is based on the highest dose that they can tolerate based on their blood pressure and their heart rate. Okay, so this is a paper that we published with Greg Armstrong that was published in Journal of Clinical Oncology. What is interesting about this particular study was that we also have sibling data that was collected from this. So this was a total of around 7,000 patients, I believe, which submitted a survey that looked at their 4 major characteristics or 4 major cardiac events, including coronary disease, valvular disease, arrhythmia, and heart failure based on their therapeutic. On Model A or Module A, what you see are 3 graphs with radiation therapy, no radiation therapy, and what their siblings are. And what you see is the cumulative event rate is very, very high for those individuals who had radiation. Panel B is for valvular disease, significantly lower than coronary disease, but still fairly high. Panel C is our arrhythmias, relatively low in the patient population. And then panel D is heart failure. And what you see in blue is that those individuals who had radiation therapy and anthracycline are significantly higher than those individuals who got anthracycline alone, compared if they had radiation therapy alone, or if they had no radiation or anthracycline, and finally their siblings. So we always keep this in mind when we try to risk stratify our patients. In this particular individual, he received over 400 milligrams per meter square. He had over 40 gray of radiation to the mediastinum. So we would think about panel A and panel D in this particular individual when we sit down and try to risk assess him and let him know what his options are. One of the misperceptions about heart failure is that it's an old term. We believe that patients go in and out of heart failure, and when they're out of heart failure, that means that they are doing well and there are no problems. And the importance to understanding that is there's still an underlying structural heart disease that has to be treated, even though patients may not be volume overloaded. So the absence of symptoms does not mean the absence of risk. And remember, this particular individual, going into his anthracyclines, he already had a right bundle branch block. If you notice, that was never addressed. There was an EF that was normal. He was started on chemotherapy. In our world of cardiology, a right bundle branch block implies structural heart disease. A left bundle branch block can be seen as a normal variant. But a right bundle, you always want to be concerned about whether or not there's underlying structural heart disease, even if the ejection fraction is normal. So this particular individual, we started him on Coreg, we started him on carvedilol, we started him on aspirin, 162 milligrams. So the discussion we had with the patient and with the oncologist was the following. Do we do a stress test? Do we do a cardiac MRI? Or do we go straight to catheterization? His CSH was 2.5, his creatinine was 1.2, his hemoglobin was 12.1 with platelets of 231,000. What should our next step be? If we do a stress, what kind? If it's a cath we proceed to, do we do a left, a right, or a combination? Anyone have any comments or questions at this point before?
Yeah, I do. Actually, it's Susan. So can you just go back to the timelines again? So he had completed his anthracycline chemo and his radiation. And what was the time frame between completion of therapy and presentation of symptoms?
So he completed therapy in August of 2013.
Right.
So he presented in April 2014.
Okay. Okay.
So really 9 months.
Yeah. So
there is, you're right, there is something suspicious about that because this is somebody that is only 58 years old, doesn't have a lot of really significant comorbidities. Maybe this is a guy we should be worrying at year 10 or year 20s out.
Right, that's right. So that was my one comment, was that this time frame, you know, I find that you either get into trouble acutely, like when you're trying to deliver the therapy, or there tends to be more of a delayed toxicity. He's kind of 9 months, which is a little bit unusual.
That's correct.
So in terms of moving forward, I guess the one thing you mentioned is you always want to rule out ischemia, right? In your investigations, where are you?
Correct. And you're absolutely right. One of the most difficult, challenging things about this case is we could not understand why somebody who's functionally doing very well at 9 months all of a sudden has a drop in heart function. Mm-hmm. That was what was the most disturbing to us.
Right.
You're absolutely correct. Any other comments?
So would you, do you ever do, on the older folks in the 50s and so forth, do you ever do a coronary CTA as a baseline?
I wouldn't.
It's not something we do routinely. However, and this is a very good point, is somebody who's had radiation and anthracycline. especially with an underlying right bundle branch block, it would certainly be something you would consider. What you're looking for is ischemic heart disease. If you think about it, what the utility of CT coronary, what makes it very, very helpful is its negative predictive value. It has a negative predictive value of 99%. So if you see something, it helps you. If you don't see something, then you feel very, very comfortable. You're not dealing with underlying ischemic heart disease. But maybe perhaps you are right. In somebody who presents with a right bundle branch block without any symptoms, but you're worried about structural heart disease, should that have been something that was done prior to starting our CHOP? That's a very good question.
Another good comment. I mean, as oncologists, we're very attuned to doing echoes or MUGAs or whatever your heart monitoring modality is. How many of us are actually doing baseline ECGs?
Not very many, because, and in this particular case is a perfect example, he was fine. He had no symptoms. He had a normal ejection fraction. You're ready to go. You put them in our CHOP and you move on.
Yeah. So because when you go back and you talk about, so did he have a pre-chemotherapy ECG?
He did, and it showed normal sinus rhythm with right bundle branch block.
Right. So my other comment is in terms of, learning from this and moving forward, I would say probably the majority of patients do not have a baseline ECG. They have an echo,
yeah,
but not
so,
an ECG.
At our institution, we follow this fairly closely. The way that we look at it is we look at this as a pre-op patient. So in other words, if a 58-year-old person was going to the operating room, would you do an EKG on them? I think 100% of people would say yes. So in other words, we look at giving our CHOP as a fairly stressful situation. So a baseline EKG in somebody who's 58 years old would be considered a standard of care.
I think sort of as we're moving forward, and sort of putting out there, guidelines or whatever, these are things so that we need to really think about, because while it may be happening in your institution, I'm not sure it's happening everywhere.
Yes. And
so just
it's very important, and this case, I think, really highlights that, because the right bundle branch block and the sinus rhythm was seen prior to starting. Somebody with no symptoms. And a CT angio would have been a very reasonable thing to do to look for structural heart disease. And that was not done because the patient was asymptomatic.
Right.
Yeah, we're doing the CT angios. Dr. Duran, Eric, we're doing CT angios on patients, if it's male over 45 that are coming to our cardio-oncology clinic as a baseline. If it's females over 50, we're doing CT angios on them. But we do step and shoot, and the radiation dose is about 3 millisieverts, and the test takes about 10 minutes, and it's no big deal.
And then
chemotherapy, you're doing that at baseline?
On males over the age of 45, and females over the age of 50, pre-chemotherapy, we're getting a baseline. We want to know if they have coronary disease because the prevalence is so high in our population.
Right.
Dr. Erickson, one thing I would ask, referring to Susan Dent, do you routinely do EKGs on all your patients prior to starting chemo?
And of course, anybody who comes into a cardiology office is going to get an EKG as a cardiologist.
But if somebody's starting any kind of chemo, would you especially make sure that they have one?
Everybody gets an EKG that I touch.
Yeah.
Okay.
But you may not touch everybody. That's the problem. And so, from my mind, as I've sort of been going through this, what I'm trying to determine and roll out in my institution is when patients walk through the door and they're seeing the oncologist, what are the baseline investigations and elements of their history that we should be ensuring are on the chart prior to starting chemotherapy? And that's really basic, but I don't think it's very standardized.
Correct.
Okay.
So very, very good comments. All right, so we will go to the next slide, but I'll tell you what we did. We sat down and we talked with this patient, and we told him the following. We're concerned the fact that his heart function dropped within 9 months. That's not typical in an asymptomatic patient who really doesn't have any risk factors other than a right bundle branch block on presentation. And we certainly could have done a stress test, but we actually recommended that we proceed with a cardiac catheterization. And here is how we outlined our discussion with the patient. We know that patients who have radiation, who experience shortness of breath, they also can experience constriction from the radiation. So one of the things we've modified in our left heart cath is that anybody who's had over 30 gray, when we do our left heart cath, we do simultaneous pressures of the right ventricle and the left ventricle to assure that we are not missing constriction from the radiation. You don't necessarily have to have acute pericarditis to have this. So one is to evaluate that. Two is to evaluate his coronaries. We told him because of the fact he had a right bundle branch block that has been there even before he started, there's a high probability of underlying structural heart disease or ischemic heart disease, and therefore we think the best first step is to proceed with a left heart cath. When we explained it to him that way, he said, I'd rather just go straight and find out the information than to go through a stress test and then finally eventually get what the answer is. The other thing is when you look at a CT or an MRI, about 25% of CT or MRIs will not show pericardial thickening, and they can still have underlying constriction. So as part of our practice, we always do both a left and a right, as well as simultaneous pressures, if they've received over 30 gray, specifically looking for constriction because his symptoms on presentations were only fatigue and shortness of breath. He never had chest pain. So here's what we found. The coronary angiogram was done. It showed total occlusion of his right coronary that had been there probably for quite some time. He had a high-grade proximal lesion of his obtuse marginal, his first one. It was a 3.5 millimeter artery, so supplies quite a bit of blood to the lateral and posterior wall. So he had a bare metal stent to the first obtuse marginal. The right coronary was left alone. Now, one of the important things in relationship we have with our oncologist, we specifically try to use bare metal stents far more than drug-eluting stents. And here's the following reason why, is we make the assumption that the most common thing that will happen to an oncology patient is either recurrence of their cancer or a new malignancy. So we tell our patients, because there's a high probability within 1 year you will have a biopsy, either related to your cancer or some other cancer. We don't want to find ourselves with you having a drug-eluting stent that we have to commit you to aspirin and Plavix for 1 full year, and everybody is put in a bind because we can't stop it. So it's an important concept that we really try to get across to the patient and for the oncologist. We don't want the oncologist to be faced with having to make a decision about stopping standard of care for a drug-eluting stent to do a biopsy. We want them to be able to do it safely. So simultaneous pressures were done. There was no evidence of arterial dyssynchrony. He was on statin, beta blocker, dual antiplatelet therapy. What is the probability he may have dual antiplatelet therapy discontinued? Probably pretty high. So we make every effort to use bare metal stent and drug-eluting stent unless our backs are really against the wall. The takeaway from this message is that the presence of adriamycin and mediastinal radiation makes him at higher risk for left ventricular systolic dysfunction. However, ischemic heart disease is still the #1 cause of systolic dysfunction in the U.S. population. So this is a patient who would have been very easy to say the adriamycin did this, start him on medical therapy. He really didn't have a lot of symptoms and move on.
I think that's really good, Jibby. I think the one thing that kind of made me think about it more was the timing, and that was the one thing that would have made me think maybe it's something else.
You're absolutely right. And that was the reason we were so aggressive, because it didn't make sense. Absolutely correct. Any other comments from individuals about this approach.
Dr. Duran, if you had done a cardiac CT prior to radiation treatment and adriamycin, and you'd found the totally occluded right in the high-grade proximal OM1, what would you have done in an asymptomatic patient prior to chemotherapy and radiation?
So in this situation, you're absolutely right. What I would have done is I would have put them on a treadmill. And part of the difficulty that I still struggle with is the concept of an asymptomatic patient in a cancer patient. So cancer patients are walking around with high levels of inflammatory markers and cytokines, such as TNF-alpha. And they're fatigued all the time. They don't walk around to get their heart rate fast enough to have symptoms. So they come to your clinic, kind of sick, and they tell you, well, I don't have any chest pain, so we tend to not pursue that any further. If we did a CT, I would make them walk and prove to me that they can walk for 6 minutes, 5 minutes, whatever time they can do, without any ischemic changes and without any nuclear changes. That would be our approach.
I see. We've had the problem that we've addressed with SPECT scanning is the dumbing down of SPECT scanning in the real world. And so Blue Cross Blue Shield found a 40% false positive rate in Michigan with a 65% false negative rate. Here in Tampa, we've seen some variabilities of that, but frequently 50-50, 50% false positive, 50% false negative. So basically, we've seen that because the hospitals have cut cost with nuclear scanning, and so instead of having dedicated techs, they have body floppers. There's no longer a doctor present and during the test, and so basically we've seen this corruption, generally speaking, throughout community hospitals, university hospitals. There's a university hospital we found with an 80% false positive rate. We found 88% false positive rate on a study that was done in Ottawa for Susan Dent, and so the SPECT scanning has become nonsense, and so we quit doing it. We decided if this is such worthless data in so many places, we decided to do Lexiscan MRI. We decided to convert to PET because there's always the test goes very fast. It's a 23-minute test, and the doctor's present, and so you can't have a body flopper. You have to have a good tech to be able to do PET. So we decided to convert over to those things. Our cardiac CT, we do that more frequently. We're interested in the heart flow study, which will be approved by the FDA in about 4 or 5 months. It'll be possible to be able to measure the resistance across the coronary vascular tree just by using a supercomputer and cardiac CT. So those are some of our challenges we'd like to throw out to you.
So those are excellent points, and I agree. With the nuclear, there's always that concern. Some labs, like ours, will also use dobutamine stress or a bicycle echocardiogram stress test, which also is very good. But the other important point you brought up was we forget that when patients come into town to be treated for their cancer, they have many, many follow-ups with oncologists, with procedures that they get on the oncology side. And tests such as Lexiscan and PET will allow the patients to move through the clinics quickly. So that's a good point.
I'd like to ask attendees to, when they're not speaking, to mute when they're not speaking. Okay?
Yes.
Yeah, I don't even think they do stitches.
So that's a good point. You brought up an We want to look at how patients flow through the clinics. And the lesson I've learned is that when I'm seeing a patient in clinic or doing a procedure, it's also tied to many other oncologists. So you're absolutely right. If we could do a PET or a Lexiscan for the oncologist in the room is a way now that we can do a stress test where it's an IV bolus and basically it's an IV push. It's far better than the 4 hours we used to spend waiting to scan individuals. So this next slide comes from the SOLVE study. If you look at the data on this, this is from nearly 25 years ago. But it really sends up the point that remember with the study of left ventricular dysfunction, this was the first study that looked at using ACE inhibitors for patients with systolic heart failure. There was a control and then a prevention arm, which were patients who were asymptomatic, and a treatment arm. And what this particularly shows in the biomarker arm was that in individuals who have no symptoms at all, the prevention arm, they still walk around with high levels of norepinephrine and renin, suggesting that biochemically they still have the disease even though they have no symptoms. We know from all the ACE inhibitor trials that they clearly reduce mortality compared to controls and all the major trials that were done, on average about 25% versus 25% in the control population. ACE inhibitors since 2001 have been a standard of care, and again I have to emphasize that can be very difficult in a cancer patient when you're dealing with issues of a blood pressure of around 100 and they feel fairly sick. So even though these guidelines are written and we know that it's standard of care, we're always very, very careful about renal function, the ability to get patients on an ACE inhibitor because of their blood pressure. We know all the potential benefits of beta blockers. They decrease heart rate, they decrease sympathetic tone, they increase vagal tone, they decrease ischemia, heart rate and blood pressure, they prolong diastole so you can fill your coronaries, they have an anti-inflammatory component, and they can reverse cardiac remodeling. All of the beta blocker trials, from the US carvedilol to BEST and CBUS, all show anywhere from a 65% reduction to a 35% reduction in mortality, looking at class 2, 3, and 4 heart failure. So when we approach this, we approach every patient by the following. What is their heart rate? What blood pressure do we have to work with? What is their creatinine? And what is the etiology? So if we see patients whose blood pressure is borderline but their heart rate is a little bit fast, we will tend to reach for a small dose of a beta blocker, only because we don't have to worry about as much about their creatinine, and we can still slow their heart rate down and still potentially improve their heart function. In a perfect world, we'd like to be able to get them on both drugs, but that can be fairly challenging in a cancer patient. Carvedilol and metoprolol are the drugs we predominantly use, as well as bisoprolol, which has an approval in Europe, as well as here. But all the data really resides with carvedilol and metoprolol, the long-acting form. The short-acting metoprolol has never been found to be effective at reducing mortality and does not have an FDA approval for systolic heart failure. So I always like to keep this in mind, is when you use Toprol XL, in order to gain all the maximum mortality benefit, you have to get up to 150 milligrams daily, which is extraordinarily difficult in a cancer patient. However, with the carvedilol, the MOCA study showed that even a 6.25 dose, there is a linear relationship. The higher the dose you get, the greater the improvement in ejection fraction. And the way this study was designed, these patients were enrolled so that they would stop at 6.25, stop at 12.5, stop at 25. These were not patients who failed higher doses and went back to a lower dose. And that correlated from the same MOCA study, a linear relationship with reduction in mortality and reduction in hospitalization. So even if we can't get patients on a maximum dose, we still know a 6.25 BID dose will still help our patients in terms of mortality and still help them with hospitalizations. And again, this is a standard of care. We've known this since 2001 when this became part of the guidelines. This is Janelle Cardinale's data published in 2010. The important point that I always find about this is the following, is that 64% of patients had at least a 10-point improvement in ejection fraction if they were started on ACE inhibitors within 1 to 2 months. However, if you look at 6 to 8 months in this data, no patients improved their ejection fraction. So this really, for me, always gets down to the issue of surveillance. So if you see a patient in January and they're asymptomatic, and you do an echocardiogram on them and it's normal, and they present to you around the holidays in December, and now their ejection fraction is 35%, there's a fairly low probability that their heart function will get improved if their heart function drops sometime between January and June. So it really bears the idea, and I don't have an answer to this about the surveillance part. How often should we be checking patients who had anthracycline-based therapies per year? And I don't have an answer to that,
Right.
but it certainly begs the question, what happens to individuals who walk around with asymptomatic drops in EF and they don't recover, and you start them too late? Fairly low probability they're going to improve.
Yeah. So, it's Susan again. So that's the million-dollar
Yes.
question. So it's a breast cancer treater giving lots of anthracyclines in the adjuvant setting, and you know, trastuzumab and more anti-HER2 targeted agents. You know, there really is no literature out there that talks or recommends monitoring once these patients have completed their chemotherapy. So, and interestingly now, sort of the movement in oncology is towards discharging patients earlier with what they call survivorship care plans, right, back to the care of their family physicians. So it's a real challenge because now we really we need to start thinking about not just risk of recurrence of their cancer, in this case breast cancer, but how do we monitor these individuals? And it's a big question mark for me.
And it is for me also, because as you said, there's no data, so we go strictly by what we think makes sense. So we don't routinely do echocardiograms on them. So what we do is we see them in clinic. We look at their exercise performance. We do a physical exam. We try to tease out that they don't have shortness of breath or fatigue, and you certainly can miss that in a young woman with breast cancer.
Right.
So we still get back to the same thing. After they've completed therapy, then we're looking for symptoms, and what pushes us to do the echocardiogram is the presence of symptoms.
Right.
We will do a random BNP, because if we see it's elevated compared to baseline, then that helps us to do an echocardiogram. One is because the BNP is pretty cheap. No one really kind of argues about that.
Yeah.
We're still left with an unknown, and we don't have a right answer to that. So we see them as what we call a well-woman visit. They come to us every 6 months, and we do a routine physical exam. We check them, make sure that they're doing well, and we have them come back in 6 months, and we do an echocardiogram if they show us any signs at all of any symptoms. And
So
I
what
wish
would
I had
be
a better answer.
Yeah, what would be helpful is to almost to design, and we can do this like a little checklist, right? So that if there was a checklist, it wouldn't matter whether they were being seen by you in your clinic or the oncologist or an advanced practice nurse or family physician. There could be like a little checklist of these are the things that you want to check for, and that if any of these are present, then you might want to consider doing an echocardiogram or other investigations.
That would be very helpful. If some of us could come up with an algorithm like that, that would be great.
I'm writing all this down because I can never remember all of this afterwards. So, okay.
So with cardiology data, we know the people who have at least a 10-point improvement, they have far less their event-free rate is much better than individuals who do not respond or had minimal response. So we have a paper we just published in American Journal of Cardiology just last month. We did this with the Cleveland Clinic. We scanned in 2009 all of our patients who had ejection fraction of less than 50%. That worked out to be a little over 7,000. What we looked at in this database was we wanted to find individuals who had a pre-treatment echocardiogram that was normal and then presented with an EF of less than 50%. That brought us down to 366 patients that had an EF, and then if they had a previous normal, that worked out to about 104 patients. 55% of them recovered with medical therapy. The predictors of recovery were those individuals who were younger age, i.e. less than age 50. Those who had small left atrial volume index, those usually show up on echocardiograms, and you just divide that by their body surface area. So the volumes will show up on the echocardiogram. And those who had lower BMPs. So when we did a multivariate analysis, we looked at a number of these agents, these factors, the chemotherapy, the EF at baseline, the left atrial volume index, the BNP. Those were the ones that were the most significant, the age, the left atrial index, and the BNP. And what we argue is that when you have an individual who has a large left atrial volume compared to their body surface area, that can be an indication of volume. So what you have is a non-compliant ventricle, and the left atrium enlarges in order to increase its amount of delivery into the left ventricle. So individuals who have not had time to increase their left atrial volumes, their ventricles are still fairly compliant, and they have an ability to recover. So when we looked at the overall cohort survival, we looked at the number of subjects at risk and the probability of survival over the course of 3 years. We found that over the course of time, at 50% survival, we see that roughly at about close to 2 years. So, and these are a population of patients with all kinds of LV dysfunction. So this includes leukemia, anthracyclines, amyloid, etc. So the mortality is pretty high at 50% at close to 2 years. When you look at, though, and you tease out individuals who recovered versus no recovery, that's where you start to see a substantial difference. The recovery in gray, those individuals who do fairly well over the course of several years, it's the non-recovery who do not do well at all. And that represents 45% of patients in this cohort who did not recover, meaning they did not have a 10-point improvement. Not 10%, but 10 points. So they didn't go from 35 to 45. And when you look at no recovery, partial recovery, and full recovery, you see the same sort of effects, that those individuals who have full recovery, which we define as greater than 50% in those particular patients, only a small number actually went back over 50%. They had the best outcomes, followed by partial recovery, and no recovery had the worst outcomes.
So Joe Carver
Jay?
has a question, I believe.
It's Joe Carver,
Yes.
JD. How are you?
Yes, good.
So I just got unmuted. I just want to comment about your study and then throw in a piece that was in Jack from a collaborative group that included the PEN people, not cancer
Yes.
patients. That
Yes.
that there's now a new subset of heart failure, and it's patients with recovery. It's, there's systolic dysfunction, there's HFpEF, and now there's a group of people that you're describing also that have had heart failure and a reduced ejection fraction, and it normalizes. They're still ultimately at risk long-term for recurrent disease under sequential stress.
You're absolutely correct. You're 100% correct. These,
So, when they come and say, okay, let's stop the ACE inhibitor and the beta blocker because I'm normal, or their primary care doc wants to stop it, you should not do that.
You're absolutely right. And part of the thing I always remember several guidelines ago, and they've taken this out of the heart failure guidelines, is that once you have structural heart disease, you have it indefinitely. In the guidelines, we always used to look at that, even if your heart function recovers. Now, with cancer patients, why we think would not be a correct thing to say. Remember, with anthracycline in the mitochondria, definitely, you never get rid of the anthracycline
not the
in your
letter,
mitochondria.
but just your own germs. Yeah, I mean, I feel like I'm hospital.
That's right.
I know. They don't post any
I just want to make
I'm like, we all
finish up about, in part of patients who have underlying heart failure, but still have hypertension. I always refer to the HEP study, which was the African American heart failure that used Bidil, which was a drug that was approved predominantly for hypertensive cardiomyopathy, and it's a nice drug that you can add on top of an ACE inhibitor and beta blocker in patients that are hypertensive if you want mortality on top of routine therapy.
What we use to try to...
We do not use DIG in our patient population for low ejection fraction because of this slide and because there's so many drug-drug interaction with digoxin and chemotherapy agents. It's far more difficult to manage these patients. So digoxin is the last resort. We do know, as it was brought up earlier, that these patients respond very nicely if they have tyrosine kinase inhibitors that cause their cardiomyopathy, to ACE inhibitors and beta blockers, if they have systolic and diastolic heart failure. And when do we refer to an advanced heart failure specialist? If they're intolerant or refractory to ACE inhibitors, ARBs, or beta blockers, if they have one hospital admission for heart failure in the past 6 months, that warrants a consult to one of our advanced heart failure people. If they have a QRS on EKG that's greater than 140 milliseconds, then we make sure they're seen by an advanced heart failure specialist. If they have chronically low sodium, less than 130, we send them to a heart failure specialist. If their end diastolic and end systolic dimensions or volume are increasing, regardless of whether or not they have symptoms, we have them see a heart failure specialist. So that's the end of the presentation. I'm open for any questions.
Susan, I think you have a question.
No, actually, I just wanted to speak to Joe later. But I'm fine. I think that was an interesting case. It really does have me thinking about how we should be looking at these patients when they start their treatment. And by that, I mean from the oncology perspective, because they will not be seen by cardiologists unless we necessarily refer them, or they're being seen already for another reason. But I like the idea of, this sort of algorithm, at least trying to get some consistency in baseline collection of information so that we can get an earlier indication of problems or refer them earlier. So in our center, not all cancer patients are referred to our clinic, but we want to make sure that we refer those people that need to be, and earlier rather than later, particularly when we're looking at trying to prevent some of these consequences.
So Susan, can I ask you a question?
Yeah.
In your practice and in your hospital, how do you think it would be perceived if you basically said, we see going on cardiotoxic regimen as a pre-op patient, therefore we're recommending everybody should get a baseline EKG if they're over age 50. Well, how would that be received if you made that kind of moratorium?
I don't think there'd be a problem with that. There would not be a problem with that. I think we could do that, and I think that would be interesting to do that. We don't really have, per se, in our environment, I'm not restricted in terms of what I can order. And so if we say, they're going on a chemo, we already order based on echoes, right, on all of these individuals. So I don't think an ECG would be a problem. We could just make it a part of the standard. This is the package, sort of pre-treatment package, if you want to put it that way, like a pre-op checklist. This is your pre-chemo checklist.
Correct.
I was going to say that. Excuse me just a second. I was going to point out that the BNP as a Baszler test is $23 at Walgreens drugstore.
Wow.
In Phoenix and in Palo Alto now, as Theranos gets associated with Walgreens, and the troponin is $6 for a troponin, $23 for a BNP at Walgreens.
Is that a regular troponin? That's a regular troponin?
I don't know what troponin it is. It's not specified on the Theranos website, but Theranos is expanding.
Wow,
they're expanding into the Walgreens across the country.
That's crazy. That's a pharmacy, though, isn't it?
Walgreens is a pharmacy, but they have nurse practitioners in a clinic, and now they're having laboratory testing.
Wow, that's incredible. Okay.
Susan, I think one thing that that Dr. Harrison said that I thought was important is with the CKG,
Right.
that really gives you the idea that if you see abnormalities such as a right bundle branch block or a left bundle branch block, and you're concerned about quality of nuclear testing, that is not a bad idea as a screening to do a CT angio as he described, a CT of the coronary, because
So
you'd be looking for structural disease anyway.
So I think what we're going to do is we're going to, at least I think the easiest way to do this, what I'm going to try and do is develop a pre-chemotherapy checklist. And on that, you include, your baseline echo, ECG. Also make sure that you take, cardiac history, right, risk factors and so on, and that it be an algorithm, if this, then this type thing. I think that would be really interesting to do. And I don't think it's being done. I mean, I think we're all doing different things. I'm not sure if we're doing everything in a similar fashion.
Now, can I add one little bit to your algorithm, which I think is a great idea?
Okay.
So UCLA had done a study about 10 years ago where they were having difficulty having cardiologists start patient on a statin prior to discharge from a hospital.
Okay.
So what they did was they did an educational series. Basically, they would flag a patient who had an elevated cholesterol, and the cardiologist would just be reminded. So they looked at individuals that the cardiologists that were enrolled in this trial to get a reminder for starting an aspirin, starting a statin, versus the usual care, doing nothing. And you're not going to be surprised by the data. What it found was those individuals who had a reminder, there were less hospitalizations, less myocardial infarction, less MI, just by prompting doctors to do those things. So with your study, you could do the same thing. You have one group that follows a checklist, the other that doesn't. You do that for 1 year, and at the end of the year, you show that the fact you get an EKG, you do these checklists, patients end up getting better outcomes because they're better prepared for chemo.
Right. It's interesting you should say that, because we're just writing up a paper looking at the rate of febrile neutropenia in patients who have this type of chemotherapy called taxotere cyclophosphamide. So what it was a prompt for physicians to order growth factor or antibiotics with the chemo versus not. No prompt, so we did it before and after. And the incidence of febrile neutropenia in our institution went down dramatically. And then a number of physicians who ordered either antibiotics or growth factors went up exponentially. Interesting.
Oh my gosh, why don't you do? I'm like, that's a great study.
Yeah.
You could duplicate the exact same thing with what you're doing with the checklist. That's fantastic.
Yeah, so it's kind of neat. Because we can actually do
you already
it, right?
have the.
We can do it because everything's electronic. We can actually even make it come up before the chemo orders, right? Or before you order anything. We can do it all electronically as well. It comes up as a prompt.
Absolutely.
Cool.
That is fantastic. That would be a great study for you to do.
Easy.
And you can publish that.
Yeah, that's kind of cool. I like that.
Yeah.
So if there's anything else you can think, I'll show you the checklist. I'll make one up and I'll show it to you for some input.
Great.
We can do that. Easy. Okay, good. That's great.
I would add one other thing to your checklist, why it's so important. This case was about anthracyclines.
Yeah.
But we forget with a lot of the newer agents, there's still a concern about QTC prolongation, and it's to have that as a baseline if they're going to be getting antifungals, antiemetic, or some of the newer agents that may prolong QTC. Another reason
so we
to
can
get
do QTC. The other thing is you would not believe, you as cardiologists are very good at doing blood pressures, but guess what? I can guarantee you a lot of patients coming through the clinics, they don't even get baseline blood pressures done.
Wow.
Yep. Until they're in the chemotherapy unit, right? Which is right before they're about to get their chemo. But baseline blood pressure, I think that's pretty important.
Absolutely.
Let's see.
It's these things, right? The little things, but they're things.
Dr. Duran?
We weigh them.
Yes.
We have a special
Yes.
cost-effective program that we developed for coronary CTA, where basically with low radiation, which is step and shoot, and iterative reconstruction, we've been able to reduce the dose to 3 millisieverts or lower. And with that, we actually have a cost-effective, there's nothing to do. You don't have anything to post-process. And so we were able to negotiate a cost of $264 for the technical as well as the professional. That's the global out-of-pocket, $264 for a $3,000 test. And so we've been able to get that, and so we do them routinely several times a day because we don't have to go through the insurers, which is such a difficult trip because they put that across a list of something they want to deny. And so that works out pretty well.
That is fantastic. I wish there were more places that can have that available, because I think that's a great thing to offer patients for that inexpensive of a test.
Do we have any other questions or comments?
Okay, sounds great. Susan, I will put you on the list for the tumor board.
Okay, thank you.
Dr. Duran, that was excellent. Thank you so much. Thank you so much for the attendees. We appreciate your coming. I appreciate your comments. Bye-bye.
Great, thank you. Bye.
Thanks.